Κύριε Φρετζάκη, ευχαριστώ πάρα πολύ για αυτή την εντυπωσιακή εισαγωγή που μου κάνατε και χαίρομαι για που βρίσκομαι εδώ. Πραγματικά με τιμά η πρόσκληση αυτή και χαίρομαι ιδιαίτερα διότι ο καθηγητής μου, ο κύριος Καρπάθιος, βρίσκεται εδώ με τη σύζυγό του, τη καθηγήτρια Ξένια Νικολαίδου, με τους οποίους διατηρώ σχέσεις για πάρα πολλά χρόνια και ελπίζω να συνεχίσουμε για τα επόμενα. And, όπως είπε ο καθηγητής Φρετζάκης, λείπω στην Αμερική κάπου 45 χρόνια και έχω δυσκολία με την ελληνική γενετική ορολογία, διότι πολλοί από αυτούς τους όρους δημιουργηθήκαν τα τελευταία 40 χρόνια περίπου. Και δυστυχώς, παρά το γεγονός ότι θα ήθελα να μιλήσω στα ελληνικά, η ομιλία μου θα είναι στα αγγλικά. Και για να μην χαλάσω περισσότερο χρόνο, θα αρχίσω την ομιλία μου, την οποία την άλλαξα από γονιδιακές παρεμβάσεις σε γενετικές παρεμβάσεις στην Νωτιαία Μυϊκή Ατροφία, διότι δεν πρόκειται να μιλήσω μόνο για γονιδιακή θεραπεία, αλλά θα μιλήσω για τις άλλες θεραπείες οι οποίες υπάρχουν αυτή τη στιγμή για την αρρώστια αυτή. Εδώ είναι τα disclosures, το οποίο δείχνουν ακριβώς τι σχέση έχω με διάφορους sponsors, από το NIH μέχρι ιδιωτικές εταιρείες, αλλά δεν έχω προσωπικές οικονομικές σχέσεις με αυτούς τους sponsors. Απλώς έχω funding. So I'm going to talk about 5q proximal classic SMA, which, as you know, is an autosomal recessive condition caused by loss or mutation of the SMN1 gene and retention of the SMN2 gene. And that's important, that retention is important because that's the reason why humans develop SMA. SMN1 and SMN2 genes encode the survival of motor neuron protein, and I'm going to refer to them as SMN from now on. And SMA is caused by decreased levels rather than complete loss of the SMN protein, leading to selective dysfunction of motor neurons in the spinal cord and brainstem. And I say decreased because total loss of SMN protein is not consistent with life. So if a fetus, for whatever reason, does not produce any SMN protein, you're going to have embryonic lethality. So it is a very important protein. The description of SMA goes back to 1891 when an Austrian physician by the name Guido Wertnich και ένας άλλος so another German physician by the name Johann Hoffmann described SMA at that time, and it took about 100 years for so it described in 1891, 1893, and it took about 100 years for the three-type classification of SMA to be developed. In 1991, although Victor Dubovich was a famous neuromuscular physician from the UK, he did define the three groups back in 1967. But even at our hospital, at Boston Children's Hospital, these two physicians, Randy Byers, who was the chairman of Neurology at that time, and Betty Bankier, a famous pediatric neuropathologist, published this paper in Infantile Spinal Muscular Atrophy, where they describe primarily type 1 SMA and to some extent type 2 SMA. So there were efforts to classify SMA, but the final one was really at the European Neuromuscular Center workshop in 1991, led by Ted Mansat. Ted was my chairman of neurology when I was training in child neurology in Boston. So we have the main three types, type 1, type 2, type 3. The type 1, the severe form, with onset between 0 and 6 months of life. And before they discovered these disease-modifying treatments, the life expectancy was less than 2 years. And then we have type 2 SMA with onset between 6 and 18 months. And these are patients, about 70% stay alive at about 25 years of age. And then we have type 3, with type 3A with onset before the age of 3 years, and type 3B after 3 years, which is the milder version of SMA with almost normal lifespan. And then we have SMA type 0 that has clearly prenatal onset. And these are the babies who used to die within the first 6 months of life. And type 4 is the adult form of SMA with onset after 2.5 years with normal life expectancy. So the classification of SMA as we know today, it's a functional classification based on function, with the understanding that we have significant overlap between the different subtypes, and also that we're dealing with the continuum of severity across the phenotypic spectrum, because it's not so distinct. As I said, there is overlap. So we have type 1, the severe form, with onset, as I said, during the first 6 months of life. These are the babies who never sit unsupported. So this is why they're known also as non-sitters, with limited survival. Then we have type 2. These are the sitters, because they never stand or walk but sit at some time. And we talked about the onset and better life expectancy. And then SMA type 3, these are the walkers, or the milder version of SMA, with onset, as we said, after 18 months of life. They're able to stand and walk at some time, and they have almost normal lifespan. Excuse me. So this is the typical appearance of a baby with type 1 SMA. And you see they have this expressive face because we have preservation of function in the face. And this is this information that many of the attendees must have already, but for the sake of completion, I decided to present some of this information. And so this is the bell-shaped chest and the paradoxical breathing and frog leg position and the typical appearance of a hypotonic baby. You can see here, I'm pulling this baby up to the sitting position, significant head lug. And when you try to lift the baby does fall through your hands because they have severe hypotonia. So this is the severe form. And this is a type 2, the sitters. So this child is sitting, and also this one here has type 2 SMA. And this beautiful girl here also has SMA, but he has type 3 SMA. So this is, she was ambulatory at the time. So SMA is one of the most common neuromuscular conditions in infants and children. And it used to be the most common fatal genetic disease in infants before the discovery of these treatments. And here we have a lot of information about the incidence. And we used to say that on average, the incidence is about 1 in 10,000 live births. And in this paper from the US, which is a multiracial, multinational country, you know, the number was 1 in 11,000. And if you think that there are 4 million births in the US, we're talking about 400, 700 SMA births per year. In our state, in Massachusetts, we have about 75,000 births, about 6 to 7 SMA births per year. But this is changing, and we get back to that. The incidence seems to be going down. But what is remarkable is really the carrier frequency, which is about 1 in 50, and it's only second to cystic fibrosis. So many people don't know that this is a very common mutation in the population, because SMA is not a very common disease. So why we're having, you know, such a high frequency of the mutation, which is very high in whites, and it's the lowest seems to be in blacks. And there might be a genetic reason for that, because they have some peculiar genetic background with 2 SMN1 genes on one chromosome and 0 genes on the other. So we're talking about 6 million carriers in the United States. And this is neuropathology. You can see this is a section of the spinal cord. This is the anterior horn here, and posterior horn. You can see that you have those pyramidal cells. These are motor neurons, the anterior horns of the spinal cord. And these are the neurons that drop out, that they die. In patients who have SMA, particularly SMA type 1, we have like a paucity of motor neurons in the anterior horns of the spinal cord. And this is why we have this condition. Excuse me. So we talked about the fact that the classification was developed in 1981, and it was really in the early 1990s when the gene for SMA was mapped to chromosome 5q11.13, and the SMN genes were identified and cloned by Melki's group at University of Paris. And that's when the molecular era of SMA started. So here's a schematic that shows the localization of the SMN genes, and it's an area of invariant duplication with two genes. The first one is the SMN1. This is the gene that is deleted in a homozygous way in patients who have SMA, and this is the gene that produces full-length SMN protein, 294 amino acids. But humans, and not necessarily other species, they have a second version of the SMN gene known as SMN2, which differs from SMN1 by 5, some people say 10 nucleotides, but one of them is very critical. It's a CDT transition at position 840 that inactivates an exonic splicing enhancer and simultaneously creates an exonic splicing silencer. So that means that most of the product of the SMN2 gene is not functional. And talking about 95% is not functional. Talking about it's truncated, and it gets degraded by the cell. And only 5–10% somehow reads through, and you end up with full-length SMN protein. The reason that happens is that when you have deletion of exon 7, the transcription proceeds into exon 8, which it creates what we call a digron. And digron is an amino acid sequence that, when it's inside in a protein, it does attract intracellular proteases, which degrade the protein. So this is the reason why the SMN delta 7 protein is not actually functional. But this is the reason for why humans develop SMA, because we have zero production from here because both copies are deleted of SMN1, but we have a small production of full-length protein from SMN2, which allows the fetus to go to the end of the pregnancy and be born to develop SMA at some point of his or her life. So it's sort of peculiarity of human genetics. So we talked about SMN1 on chromosome 5, and this is the gene that is deleted, as I said, in 95% of the patients have a deletion of exon 7 and 8, or just exon 7 in both copies of the gene. And we talked about the SMN2 gene, which is similar to SMN1, it produces only a small amount of full-length protein. So when all this thing unfolded in the 90s, late 90s, we're wondering why we have 3 types, in fact 5 types of SMA. And the reason has to do with the number of the SMN2 copies. Most babies who have SMA type 1, as many as about 75–80%, they have 2 copies of SMN2. And the ones who have SMA type 2, the sitters, most of them have 3 copies of SMN2. And the ones who walk, it's about 50–50, either 3 or 4 copies of SMN2. So this is the main reason, this is the main phenotypic modifier that explains the variability in the expression of the disease in patients with SMA. And there are also some other modifiers like this CF859 C2G substitution in in exon 7, and also this one A-44G change in intron 6 that make the phenotype milder. But this is the main phenotypic modifier. So because of that, people felt that we should try to exploit the fact that we have a second, we call the backup gene, an ortholog or pseudogene. If we make this SMN2 gene to produce more full-length protein, we might be able to treat this bad disease. And the other option would be to replace the SMN1. As I said, SMN1 is deleted on both chromosomes, and it is a way with gene therapy to replace it or insert the correct version, then you may have a therapeutic outcome. So in that sense, SMA became a unique translational disease because the genetic defect is the same in all patients. Whereas in other genetic conditions, for example, Lou Gehrig's disease or ALS, you know, it does vary, and we have clear targets. We have the SMN2 and the SMN1 gene. So that was exploited, and there was a number of trials that are conducted in the early 2000s, you know, using neuroprotective agents like riluzole, gabapentin, or amplification, known drugs like phenylbutyrate, hydroxyurea, valproic acid. They were known to amplify SMN protein in the Petri dish, and people felt that maybe we can use these known drugs to treat SMA, but all these trials actually failed. So it was around year 2000 when there was an NIH conference, and everybody felt that SMA was a low-hanging fruit, as they say, an easy disease to try to treat, because, as I said, we have clear targets. And it was 2004 when the Pediatric Neuromuscular Clinical Research Network for SMA was created by myself in Boston, by Daryl DeVivo at Columbia University of New York, and by Richard Finkel, a chap in Children's Hospital of Philadelphia, with the Data Analysis and Bioinformatics Center, University of Rochester, with support from the SMA Foundation. The SMA Foundation was created by a couple who had a girl with SMA, the investment bankers in New York, and they invested more than $100 million of their own money to develop a treatment for this disease. They did not rely on donations, so they used their own money to develop this network, which was, as I said, were three centers. And more recently, we got funding till about 2019, 2020. And since then, Cure SMA, which is a national organization, provides money for this research. I mean, it's not the only source. And then we included also Nemours in Orlando, where because Finkel moved, and in any case, and Stanford in California. So this is the network was created. And our objectives were to study the natural history of the SMA in a genetically and clinically well-defined cohort of SMA patients. It's very important to know the natural history before you do any clinical trials, because if you don't know how the disease behaves naturally without any treatment, it's very difficult to conduct clinical trials. You need to have like a benchmark to compare it to something that's, you know, which is the natural history of the disease. The other objective was to establish network infrastructure. We had to include people like physical therapists to administer outcome measures, to develop new outcome measures, as we say here, to validate them, and also to conduct clinical trials for SMA and contribute to the development of an effective treatment within a decade or so, and of course provide comprehensive care, which happens to be multidisciplinary. So the first genetic intervention was based on antisense oligonucleotide technology, and was initiated by basic scientists at Cold Spring Harbor Laboratory, but also in a company known as ISIS Pharmaceuticals in San Diego, now known as Ionis, and others, where they screened a number of oligonucleotides, and covering intron 6 and exon 7 and intron 7. And one of them, known as ASO 1027, but later on we called ISIS SMNRX, now it's known as nusinersen, was found to induce long-term retention of exon 7 after intraventricular infusion in SMA mice. So there was also a model of SMA, an animal of SMA that was created, known as SMN delta 7 mouse, to do all these experiments. And what this oligonucleotide does, it binds to a site known as ISSN1, intronic silencing site, which by doing that, it blocks the binding of a heterogeneous nuclear ribonuclear protein that tends to inhibit the inclusion of exon 7 during the splicing and the transcripts. So basically, it inhibits the inhibitor, and by inhibiting the inhibitor, it enhances the inclusion of exon 7 during splicing. And these are experiments that were done in mice by putting a catheter intraventricularly and infusing the drug. And you can see the retention of exon 7 went from 5% to as high as 90% and lasted for 6 months or more. So that was then evidence that this was going to be a drug for SMA. And better evidence came from doing experiments in the SMN delta 7 mouse. This is a 9-day-old untreated SMA mouse. You see how small it is? It tends to develop necrosis of the ears, of the paws, and the tail. It's very, very small. And after treatment with this particular antisense oligonucleotide, you see the difference, 9-month-old mouse given this therapy. And this was in a publication, Nature Medicine, in November 2012, and they called it choline the backup. The backup was the SMN2 gene. And I don't want to give you a lot of details because we don't have a lot of time, but this was a pivotal study, they call this ENDEAR study, to treat children with SMA type 1. And so we have a cohort that received the drug, nusinersen, and we have babies where we're doing a sham control procedure, meaning that the PI, for example, like me, I didn't know who was getting what. They would go into a room, pretend they were doing a spinal tap to infuse the drug, when in fact they're just nicking the back with a needle to give the impression that spinal tap had been done. That's called sham control. You can see the difference. The interim analysis was 41% versus 0%. At the end of the study, 51% of the babies who received nusinersen acquired milestones. I don't want to get into details of this, versus 0% in the sham control group. So that's very, very impressive. The results were, and this is the first patient who was treated in the world in our center. In fact, it was just before I came on vacation here back in 2014. And this baby was born in the spring 2014, and then was injected in August of 2014. And then we noticed this, that not only they're surviving, but they're also acquiring milestones. I mean, sitting, something that never happens in SMA type 1. And of course, you know, look at the strength and all that. So it became pretty obvious who was getting the drug and who was getting sham control, who was sham control. And the results were published in English Journal of Medicine. And you see the survival. This was an international study, 61% versus the 32%. And the Chappington score was better. And also the CMAP, electrophysiological response, was very good, again, with the 12 milligram dose. And you can see that we noticed the best results were observed in patients who started treatment within 13 weeks after the onset of the disease. And if I can make this play. Oops. And this is the same child who got the treatment in August 2014. And you can see this is walking with a walker, something that will never happen with SMA type 1 untreated. And then we also treat patients with later onset SMA. And you can see there was clear difference in the Hammersmith score between the two. The sham control going down and the treated group going up with the same dose. But not everybody did spectacularly well. I mean, there were deaths, and there were patients who actually did not improve substantially. But these were many patients with advanced disease, were not patients who had mild SMA. And based on the results, nusinersen was approved by FDA on December 23rd, 2016. I don't know if I'm allowed to give the commercial name. In the US, usually don't do that, so I'll stay with nusinersen. But you know which medicine I'm talking about. And basically, we do a spinal tap, we remove 5 ml of CSF, we inject 5 ml of the drug, and it has to be, we have to have 4 loading doses, day 1, day 15, day 30, day 60, and then once every 4 months after that. And look at the cost. You know, 1 vial is $125,000. I mean, very, 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 very expensive. And there's some, as far as safety, it seems, I think nusinersen is pretty safe. FDA was concerned about coagulation problems and renal toxicity. These are what we call class-related side effects. You know, as a class and ASOs, they tend to give you coagulation things, but I haven't had a case with significant coagulation abnormality now for so many years, or significant renal toxicity, were more than lumbar puncture-related adverse events, and some hydrocephalus in the beginning, but we haven't seen this for many years. So it's pretty safe drug, I should say. So this is the same girl, now about 5, 6 years old, but not everybody has done as well as her. They continue to have like bulbar function issues, like swallowing, handling secretions, chewing. So, and it is an invasive treatment. You have to do a spinal tap once every 4 months. It's lifelong treatment with their delivery issues. And we don't also treat the periphery, because we inject the drug into the spinal canal. We treat primarily the spinal cord, but we don't treat the other organs. And as I said earlier, I don't think I said that clearly, but SMN protein has a ubiquitous expression. It's everywhere in the body. So it must have some function in other organs in the body. So we only treat the spinal cord and the brain, but not every child survives. So this is the best we can do, this particular drug, for symptomatic patients. And then this is about gene therapy. And this is the adenovirus. This is the childhood cold virus, which was used as a vector in a patient by the name Jesse Gelsinger at the University of Pennsylvania, Philadelphia, where this patient had a urea cycle defect, and he received gene therapy using adenovirus, and he developed pulmonary hepatic failure. He died within about 7-10 days after the treatment. And that was a major setback in the field of gene therapy because everybody got scared and didn't want to go do more experiments in other areas of gene therapy. But this is the adeno-associated virus, AAV, which is non-pathogenic as far as we know. Some of us have been exposed to it, and we have antibodies to AAVs, or AAV9 in this case. But we don't. There's no clear illness has been described in association, connected to AAV. It's supposed to have a good safety profile. I put a question mark there because there's never 100% safety, and it does provide long-term expression. So this is the construct that was developed developed by basic scientists. We used AAV9 as the vector, and this is it is a nice vector because it can accommodate a small transgene, like a small piece of DNA, like the SMN1. It does not tend to integrate into the human genome, like lentivirus, for example. So it's like it's safe in that regard. So you don't have to worry so much about insertion or mutagenesis, as Professor Katami said earlier. It's not pathogenic. It has a rapid onset of the effect. It does remain stable within the nucleus, because particularly motor neurons that do not replicate. And it has these, we call these ITRs, inverted terminal repeats, on both sides that provide sustained expression, durable expression of the vector. So just to there's a schematics here that shows the vector and the cell. And the vector tends to get into the cell using endocytosis, a clathrin-based endocytosis, and it is in the endosome. And then you have the vector, and after the release from the endosome, the vector also loses the capsid and it gets into the nucleus and stays there as an episome. So it does not integrate into the genome of the recipient, and it can be at any moment it can fold into itself and produce mRNA that gets translated into therapeutic protein. So it is a very good vector, and it does seem to work pretty fast. And the reason for that is that this in a very terminal repeat. So this is basically a repetition of what I just told you. But these ITRs, the terminal repeats, make it easier to develop the second strand. So within weeks, the second strand is created. It then allows the production of the protein much faster. This was the pivotal gene therapy trial, the first one with 3 patients who received the low dose and 12 patients who received the high dose by Jerry Mandel's group at the University of Ohio. And this is the Chapitin score, and most of our type 1 patients, they never used to go above a score of 40. So that's why we see this dotted line here. And you can see after gene therapy, this is the 12 patients. One of them didn't do very well, but the others, you see, they keep going up. And particularly those two who with early onset and a higher baseline score, they seem to hit the maximum, the ceiling, very, very fast after the treatment. And it was the evidence that things are going, this is effective therapy that was approved by FDA on May 24, 2019. We are concerned about liver toxicity, and this is why we pre-treat with steroids, starting the day before, like 1 milligram per kilogram of prednisone, and then we continue for about 2 to 3 months. And we monitor AST, ALT, the liver enzymes, and so on. And the approval was really for patients less than 2 years of age with SMA, with biallelic mutations in the SMN1 gene. And then it was approved later on by EMA and other regulatory agencies around the world. We see thrombocytopenia during the first usually week, but we never had a case our side. We treated more than 50 patients so far with commercial product, and we haven't seen a significant thrombocytopenia. It usually recovers. We monitor troponin I levels, and we had a case where it went up very high. And we did echocardiograms, EKGs, and there was no evidence of cardiac dysfunction. The truth is that there have been a number of cases of patients who develop thrombotic microangiopathy with kidney failure and intravascular hemolysis and all that, which there are about 4,000 doses so far have been administered around the world. There are about 15 cases of TMA. So as Dr. Katami said, I mean, you can have death with these high-tech therapies. They're not totally benign and risk-free. But look at the cost. It's $2,150,000 for a single dose. Very, very expensive. And then the next genetic intervention has to do with an oral SMN2 splicing modifier. So nusinersen is a splicing modifier, modifies the splicing of the SMN2 gene. This is a small molecule that was discovered by a small company in New Jersey, which is south of New York, who was very close to going bankrupt. And they discovered this molecule that when it was tested in SMN delta 7 mice, extended their life from 14 to 17 days to more than 150 days. And this was evidence that that there was going to be a therapeutic for SMA. The single dose study was initiated in Europe on adult healthy volunteers, and we're about to enroll our first patient when we were told to hold off because the trial was placed on hold because there was evidence of retinal toxicity in non-human primates, microcystic degeneration of the peripheral retina. So that really put everything on hold. And then they went back and they redesigned the molecule, and they developed in a collaboration with Roche in Switzerland. They developed a molecule that was similar to the original one, but did not have that significant toxicity. And it does bind in two sites. And it does, by doing that, it does induce some conformational changes in the small non-nuclear ribonucleoproteins that allow the inclusion of exon 7 during splicing. So there was a new product known as RG7916, another splicing modifier, different studies were performed in type 1 and type 2-3 SMA and so on. The advantages are that you take it by mouth and it has systemic distribution. As I said, SMN protein is expressed everywhere in the body. So having a drug that upregulates the production of SMN protein throughout the body might be better, might be beneficial. But you run the risk of having more side effects. So this was one of the pivotal studies of risdiplam in type 1 SMA. You can see that the survival was about 93% after 12 months, as much as 24 months. Very, very good survival. And also, whereas normally you go down like that. And also, it does, if you measure the SMN protein in the blood, it does go, it got go up by 2 or 3 times in the peripheral blood, and can be measured and it's sustained. But most important is really what it does at the clinical level, because the patients who were type 1s who never sit unsupported, they started sitting about 30%, able to sit for more than 5 seconds in a 24 months, 61%. And if you say, well, 5 seconds is not really a lot of sitting, let's say 30 seconds, 17% 12 months, 44% at 24 months, and other improvements that I cannot detail because we don't have a lot of time in the areas of of swallowing and not having so many admissions into the hospital, and no drug-related safety findings and no withdrawal from in FARFIS. We're very concerned about retinal toxicity. So all these babies had very thorough eye exams to make sure they don't develop that generation of the peripheral retina, as was known with the other compound. Was approved in August 2020, but there's some concerns about reproductive function in both males and females. Of course, pregnancy testing is recommended in females, for females with reproductive potential prior to initiating the treatment. And you really have to stop the medication before a woman becomes pregnant. And also in males, there's concern about fertility. It is a cell cycle inhibitor. So it does have effect on germ cells. And the recommendation by FDA and I think by EMA is to do sperm cryopreservation. So here we are with 130 years later since the description of SMA back in 1891, and now we have 3 approved treatments. But what determines efficacy? I think the major determinant is the number of surviving motor neurons in the spinal cord and brainstem. Because if you don't have any motor neurons here, there's no drug that's going to be effective. So it is important to intervene as soon as possible, and time is motor neurons, as they say. I used to show this slide in 2023. The 99% of the infants in the US are diagnosed at birth during the first 17 days of life. In 48 United States, in the US, you're currently screened for SMA. Also in Japan, Australia, Europe, and other countries. It was only Nevada and Hawaii that don't actually they didn't participate. It's just you need to know that when we do newborn screening, we only detect that 95% of the patients we have a homozygous deletion, and the ones that have who are compound heterozygotes with a deletion on one chromosome and a small mutation on the other, they might be missed. But as of January 8, 2024, all states in the United States screen for SMA. So we don't see symptomatic patients anymore. And this is what I said back in 2012. That was the time when the initial open-label nusinersen trials were initiated. I said, maybe we'll be able to achieve cure if we intervene early. And some people felt this was a very bold statement, sort of like, a very optimistic statement that we're going to have cure in SMA. And that was back in 2012, but the best evidence that treating early is important came from the nurture study, where you can see that these are the results of the, let's say, these curves basically represent milestone acquisition scores, And this is the ENDEAR study going up. And this is what happens if you treat during the first 6 weeks of life. The babies who have 3 copies of SMN2, they tend to behave like normal babies. And the ones who have 2 copies, you know, they seem to be doing similarly well, all alive and more, not require parenteral ventilation or tracheostomy, and at 2 years had achieved maximum High-2 scores. And this is an example of a baby who was treated at 2 weeks of life with nusinersen. And at 6 months, you see he seems to behave like a normal child. And let me see here. So he got nusinersen during the first two weeks of life.
Good job.
And here at 11 months, seems to be, you know, walking pretty well. But you can see the cost, $70,000 in the first year, and then $375,000 a year for the rest of her life. So, and then I saw the same child 2 weeks ago in the clinic. You can see, you know, how well this kid is running, and also how fast can get up from the floor, and continues to get nusinersen every 4 months. But we get similar results with gene therapy, and this is a girl who got 3 weeks of life, and now 14 months old, and you can see how well she's doing as far as motor function is concerned. But again, look at the price. $2 million, $150,000 for a single dose, but it's only a single dose. And then this is a girl who received a gene therapy, but if I remember well, we did bridging with risdiplam. Like the first 2 weeks of life, we had to give it till we get insurance approval to administer the gene therapy. But you can see how well these kids behave motorically with these treatments. But there continue to be concerns, and we'll get back to that. So these are the 3 interventions with nusinersen, on onasemnogene, parvovec, this is the gene therapy, and risdiplam, you know, different studies. And the ones that had 3 copies of SMN2, they seem to be doing the best. I mean, there are some exceptions with some feeding problems and all that. There's a lot of detail behind it. We don't have time to describe all of this. But basically, all 3 treatments seem to work if you give them early. So particularly the ones that have 3 copies, they seem to be doing the best. Now, unfortunately, 40 to 50% of the babies who have 2 copies of SMN2, they have symptoms at birth, and they're not doing as well as the ones that I showed to you. I mean, they're still doing better than ones who are symptomatic, who came to the office at the age of 3, 4, 5, 6 months for the first time, but they don't have like an optimal response. And the question is whether we should be treating in utero, and that's something that people are thinking about. And then there is the 4-copy conundrum. You know, some people feel that we should not be treating the 4-copy babies. You know, depending on where you are. I mean, in the U.S., we, at least at our center, we do treat the 4-copy babies because I believe that there's no way to time the onset of neurodegeneration. And by the time they come to the doctor with hypotonia, loss of reflexes, weakness, they may have lost as many as 50% of the motor neurons. And there's no way to bring them back once you lose them. And the other issue is really the cost. As Professor Katami said, it's really enormous cost. We're talking about millions of dollars. In the U.S., the insurance companies pay, most of them, they pay for this expensive treatment. I think they're doing the mathematics, and they feel that you pay once $2-3 million, and then you avoid all these admissions to the hospital, coming to the emergency room, and even all these other treatments and so on. So long term, maybe they save some money. But in any case, it's very expensive. There are ethical issues that have to do with these type of treatments that were described in this article in the Annals of Neurology, if you're interested. So what's the solution to this? You know, can we may have more treatments. You heard about sickle cell disease and about hemoglobinopathies, SMA, hemophilia. We're going to have a lot of this. I mean, can the medical system afford these expensive treatments? So even countries like Singapore, Singapore has per capita income is higher than the United States. It's a very wealthy country. But this is what an economist said there. The treatment has to be cost effective. It must fit in the health budget of the country. You know, if the hospital has a $10 million budget or 10 million euro budget, and the cost, and it has to treat 2 children, we're talking about $4 million. Can that hospital afford to provide this kind of treatment? So what's the solution to this? Well, the look at Tay-Sachs was reduced by 90% in 10 years by doing preconception carrier screening. Thalassemia reduced by 50-80% in 3 years. I don't know if that's accurate, but I think it's pretty close. And with preconception carrier screening, so this is why the American College of Obstetrics and Gynecology has a guideline that says, and also the American Society of Human Genetics, that if a woman comes and is pregnant or thinking about pregnancy, it has to be screened for SMA, because 1 every 50 people are carriers of SMA. So, and if the obstetrician doesn't do it and a baby is born with SMA, that obstetrician will be liable legally. So this is something that has been implemented, and this is the reason for why the incidence of SMA is going down. The statistics of 2000 and 2022 show that it's about 1 in 22,000 births in Massachusetts, and it used to be 1 in 6,000 to 11,000. In New York, 1 in 20,000. And when they put all the data together from 30 states, 6.2 million newborns, the incidence was 1 in about 15,000. So the incidence goes down. So this is, I know there are ethical issues. It's sort of like, how do you, deal with the fact that if a couple comes to you and says, well, no, don't want to have an abortion. This is against our religion. So there are ethical issues. But there's also pre-implantation genetic diagnosis and other technologies out there that make it, I think, easier. So this is a potential solution to the fact that, because the prices may not come down very fast, because SMA is not diabetes or hypertension. It's a rare disease, and these are rare diseases. So it's going to be, they may come down, but not significantly. So that's what I had to say, and thank you for your attention. For those who are interested in neurology of the newborn, this is the textbook that Professor Fragakis was talking about. The 7th edition just came out, and those who are interested in neuromuscular disease, this is the 2nd edition of our book on neuromuscular conditions in infants, childhood, and adolescence.